So what we found in our study was that, in fact, patients who received chemotherapy after first-line AR-targeted therapy actually seemed to do better. These were patients who were actually intrinsically sicker. They were younger, they had worse prognostic factors, including their Halaby score, their hemoglobins were lower, their LDHs were higher, their alkaline phosphatases were higher. So these were patients that the doctor, the oncologist treating the patient, thought were worse off and needed more treatment, more aggressive treatment, and they received chemotherapy. The other group of patients who received a second AR-targeted therapy were, generally speaking, a little bit older and had better prognostic features. Despite this, when adjusting for those prognostic features, patients who received chemotherapy actually seemed to have a trend towards an improved survival. And then when we looked at a subset analysis, when we looked at specific features like those patients who had the lowest hemoglobins or had the highest LDHs, those patients seem to actually have a more profound, statistically significant survival benefit if they receive chemotherapy. And as a clinician, we understand this. The sickest patients with the most systemic type of cancers that are progressing will not respond to a second AR-targeted therapy. I think we now have enough experience to understand this, but this poster and this study really addressed this directly by suggesting that not only should they not receive a second AR-targeted therapy if they didn't respond particularly well to the first, but that they may actually have a survival benefit if they receive chemotherapy instead.